Welcome everyone to today's webinar, The Next Gen Communication and Telehealth Plan of Action for Your Hospital. I am Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And at this time, I'm pleased to introduce our presenters for today's webinar. Dr. James Woodson is a board-certified emergency physician whose passion is to serve. He is the founder of Pulsera and the Alpine Compassion Clinic, which provides free preventative care to those in need in the East Texas community. After completing his emergency medicine specialty training at Carolinas Medical Center, James joined Leading Edge Medical Associates, providing patient care at the Good Shepherd Health System in the Longview, Texas area. While practicing, he experienced the communication difficulties we face in healthcare in diverse settings, from rural critical access facilities all the way to major metropolitan tertiary care centers. This experience inspired Dr. Woodson and his team to found the healthcare communication company Pulsera, where he currently serves as CEO. Tim Hakamaki is a CCRN certified registered nurse passionate about improving healthcare workflows. Tim is currently the Senior Vice President of Product at Pulsera, working with all internal and external teams to enhance the healthcare communication experience. Tim previously was the founder and creator of several successful healthcare products over the last 25 years and enjoys creating products that ultimately help improve patient care. Tim has also helped design, build, and support revenue cycle management solutions for several healthcare industries. And at this time, I'm pleased to turn the floor over to James to begin today's presentation. Take it away, James.
Thanks, Brian. Telehealth and telemedicine has changed a lot in the last 4 months, and we appreciate everyone joining us today as we explore new opportunities together. So some of the goals today that we'd like to go over first is really we want to overview some of the key regulatory and reimbursement changes and the implications on your system. Some of the discussion points will obviously have massive implications on the outpatient space, but our focus today is going to be really on the acute care space and hospitals in particular. So we'd also like to explore where telehealth can help us improve both the quality and the value of the care that we deliver to our communities. So we've got a really diverse audience that's joining us today. So our goal is to provide value not only to those that have been working in the space for decades, but also to those that are pretty new to the space. So some of the slides contain a lot of content, so feel free to take screenshots of the meteor slides during the presentation, but keep in mind we're also providing a handout that contains a lot of this information. So I think our point in time right now, I believe Winston Churchill's famous quote applies to this exact moment in time. Now is not the end, it's not even the beginning of the end, but it is perhaps the end of the beginning. So we can't really talk about telehealth without talking about COVID-19. As you guys all know, COVID is really driving the changes in telehealth. We find ourselves faced with so little as well as so much information and data at the same time. In addition, we're undergoing change at such a rapid rate that many are left feeling discombobulated, and they often don't really know how to react to the situation or what to do next. So to simplify, we're going to break down where we are into 3 phases. Obviously, there's the initial response. We all basically did what we had to. Back in March, we leveraged the tools that we had, and now we're starting to enter into phase 2, or as Churchill, I believe, would say, we're at the end of the beginning, and most of us are starting to enter into phase 2 in kind of evaluating, reflecting back on what we've done, how we responded, and then preparing for what's next. We really don't know exactly what's coming up next. So is this going to be a slow burn? Are we going to have rolling epicenters with waxing and waning? Are we basically going to have a large second wave? We don't really know, but we do know it's time to reflect and prepare for what's next. So I think a lot of the outpatient opportunities are pretty evident, but some questions I'd like to ask are what can we do in the acute care space to better leverage telehealth? How can we leverage it to limit clinician exposure, preserve PPE? How can we leverage it to help us load balance or transfer patients across organizations or even regions? How can we leverage to provide better access to those that are in underserved areas or communities? Can we use telehealth to help us select the appropriate destination facility or level of care? How can we use it to meet patients where they are now? How can we leverage telehealth to do things like work better with EMS, long-term care facilities, alternate care sites, and other organizations? Some burning questions in the South might be, how do we deal with a COVID surge in the middle of a hurricane? So I believe systems of care really highlight the fact that we must unite and we're all in this together. Inter-organization communication with fax, phone, and radio are obviously no longer acceptable. I personally believe that how we work with others will be the defining characteristic of our response, and I believe telehealth will be a key driver of that. So as we kind of take a step back and reflect on where we've been, what's happened, I think part of reflecting is evaluating this initial response, what worked, what didn't work. I also believe part of reflecting should also really be personal at this time. So COVID has been bad. There's no bones about it. It's been bad. But when we reflect, it's also very powerful to reflect on what's been good. Many of us have given up so much. What do you not want to let go of? So instead of just using the Q&A box that Brian mentioned a while ago to fill in questions, please take the opportunity also to list some things that you've been thankful for or something positive that you feel like's come out over the last 3 to 4 months. So on a personal note, I've greatly enjoyed cooking and eating with family at home. When it comes to healthcare, I think one of the biggest things is telehealth. So telehealth expansion is, I believe, one of the positives that has come out. There's tremendous long-term implications on quality, on value, on access that will serve for generations. Administrator Verma's famous Genie quote, I think, sums it up well. There's absolutely no going back. And what's fascinating to me is we've crammed decades of progress into 3 months. So it's really hard to look into the crystal ball. Telehealth is something that is still just rapidly evolving. Just last week, the U.S. Senate Committee on Health, Education, Labor, and Pensions met to discuss the 31 temporary federal policy changes in what should be permanent versus what should be continued. So I think overwhelmingly, some of the things that they believe should be permanent are relaxation of the originating site rule or the patient location, and I think expansion of reimbursed services, both in terms of types of encounters and the eligible providers. I think keeping those permanent to some degree are going to be in the future. Some things that we know that are going to be discontinued are the relaxation of the privacy and security standards. So a lot of us had to respond with non-HIPAA compliant solutions, and I think that time will be coming to an end. So I'll come back and discuss the implication of these more in a bit, but I'm going to pass it off to Tim Hakamaki for a deeper dive into the past, present, and future of telehealth.
Thanks, James. I'd like to start by thanking everyone for the opportunity to present today. It's truly an honor. Today's presentation, I'd like to focus on the major changes that we are all witnessing and talk about the impact of telehealth as it has forever changed the environment that we all live in. So as James mentioned, we've had significant changes in the last 3 months. So let's start with a review of what it looked like way back in history. And for us, that is the last 3 months. Prior to 3 months ago, only a small minority of systems utilized beyond 3 to 5% of the solution being telehealth. And essentially, telehealth grew to millions of claims in less than a few months. And so it's been truly transformational throughout healthcare. According to a published stat, the number of Medicare beneficiaries using telehealth services during the pandemic increased 11,700%. So you see that hockey stick growth, and where it was flatlined and then growing to millions of claims, then that timeline is 3 months. And that's just remarkable and transformational. So from a historical look back, why didn't it expand previously? And the answer is simply that policy barriers made the expansion of telehealth nearly impossible for the last 10 years. It was recognized that in the early days that telehealth was in desperate need in rural areas, but this ended up being a catch-22 because policy was written around making it available to rural areas. So Medicare telehealth coverage prior to COVID-19, services were normally provided in person and conducted via interactive audio video. And you can all visualize this as you had an individual with the patient and you had an individual sitting at a monitor that could see the interaction that was taking place. Typically only available for beneficiaries in rural areas. In most cases, beneficiaries could not be at home. Phones were not able to be utilized, and caregivers could only provide evaluation and management or mental health services. Virtual check-ins, these were not services that would normally occur in person, and they were brief and paid at a very low rate. And they could only be offered to established patients. As the rest of the healthcare, telehealth especially, these could only be offered by practitioners who could utilize those EM codes from a HCPCS code and a CPT code perspective. So telehealth going into the future, what's happening in telehealth today? So CMS provided this great roadmap for people to follow. So hopefully everyone can take a look at this and really use this as a roadmap to covering all of the services that we're going to be referencing. And I'm not going to break down all of the different details in this slide because there's a lot of detail in here. And this will be passed along to the members post-event. But at a real high level, you can see that the Medicare telehealth visits component and the related CPT and HCPCS codes that were affected, and then what interaction that you needed to have with the patient relationship or not in a previous state. So same with virtual check-ins. You have the roadmap for the CPT codes and the HCPCS codes associated to that, and also what it means to be brief, the 5 to 10 minute check. So when you look at this and you break this down, this is definitely a very powerful roadmap that kind of decides how we have to do a lot of our integration around that solution. CMS rapidly expanded. So if we look at what's going on in the current view, CMS rapidly extended the coverage of telehealth and virtual check-ins with the Medicare program. States and third-party payers quickly followed. We had that really rapid hockey puck growth, but what we saw was a really quick response from CMS and third parties to follow to allow for this pandemic relief. And no longer are we limited to rural areas. So the place of service code on the claim is no longer required to be just rural areas. And this independently has been the single largest improvement for the telehealth, but also has the largest global impact to other healthcare services, you know, like home care, mobile integrated health, as well as the other hospital services. So at a global effect, there's all kinds of things to consider along that, all different forms of healthcare. Beneficiaries can now receive services from their home, which is a phenomenal service, one of the major barriers to not expanding before. Mobile devices and phones can be utilized to provide these services, and audio-only calls are covered. An expansion of practitioners that can provide the services like STO, TPT, there's an expansion of all of those services, which include HCPCS codes and CPT codes associated to that. Okay. So virtual check-ins may now be offered to new patients, and if there's an expanded list of practitioners that can bill for these services, like I mentioned, for CPT codes and HCPCS codes. So what does the future look like? With so many changes happening so quickly, everyone is looking into a crystal ball and trying to predict the unpredictable. It's important during these times that we have a telehealth program that can allow flexibility and adjust to those changes. The COVID-19 pandemic is putting a strain on the healthcare system, but accurately capturing and documenting cases for the coronavirus can really provide a nice blueprint and roadmap going into the future. But one of the things to consider that is often not talked about is the training aspect of this for the staff and team. You know, training providers and staff on policies and practices and the protocols of using telehealth services, including things that we just don't think about, like scheduling, documentation, billing, referral processes, specialty care and urgent care and emergency care services, and so on and so forth. It's a lot of information to cover. Recapturing volume and revenue quickly with telehealth will be critical to the return of financial stability. Telehealth is growing a segment of AR, so the accounts receivable side, for most organizations, which means that they must utilize analytic-driven approach to boost that volume, maximize their revenue, and accelerate cash to resume normal operations. New systems deployed must be efficient and integrated into the clinical workflows to maximize reimbursement and allow the needed scale. New systems also must be deployed, need to have a strong focus on healthcare specific relatedness to the HIPAA compliance, as this flexibility offered during the pandemic will likely be removed. It's also important to note that Congress and other policymakers are holding sessions and feedback sessions from industry leaders on what should remain post-pandemic. All the current pandemic updates are being considered, but careful consideration is being considered on the following items, which are care from anywhere, which is a huge deal, or the lift of the rural requirement, continuation of the expanded practitioner services, which are the new CPT codes and HCPCS codes for OT, ST, PT, and so on. Also, careful thought is being placed around how to achieve payer parity, as this really adds a level of complexity to the mix if all payers have a different requirement. And just as a recent update, as of just a few days ago, all of this week, a new bill was introduced that would allow telehealth practice anywhere for up to 180 days beyond the pandemic ending. So there's a lot more to come on that, and we'll have to be following that from a industry knowledge perspective. So with that, James, I'm going to turn it back to you.
Perfect. Thanks, Tim. So I think it's important for us to realize that most existing solutions were designed to fit the old reimbursement and regulatory environment. So I think this is really important, so I'm going to say that again. Most existing solutions that we're leveraging for telehealth were designed specifically to fit the old reimbursement and regulatory environment. Over the last 3 months, I think this is why a lot of clinicians and administrators often feel like the solutions that they're using are like trying to fit a square peg in a round hole. And so when we start to kind of break down the feature set of the solutions, there's a common kind of suite that we see there. Obviously, the synchronous and asynchronous communication. On the synchronous, it's the live audio, the live video. A lot of that has really turned into almost a commodity nowadays. And so it's a lot of the other features that often start to differentiate, whether it's messaging, how we're moving data, where the integrations are, both for data flowing in as well as data flowing out. Are we leveraging technology that allows us to capture a lot of data quickly, like with images? Of course, outpatient, remote patient monitoring, things like that, multimedia, those are all key components. The documentation has been interesting to watch over the years, as the documentation and billing used to be kind of quarantined in these telehealth solutions, but often more and more that's being done through the EHR. And so when you start to look at the things that are differentiators, I think the network of care team members is one of the key things. Are you needing to access to other clinicians, other specialists that aren't in your system? Or do you have these clinicians that you're trying to make available to provide those services? How you're able to patch together and bring together groups of people that are providing services instead of just point to point with two people, often being on either end, especially if you're thinking more telemedicine mindset and clinician to clinician. How many people can we bring together? Where are they? That's starting to turn more and more into differentiators. Tim's going to talk more in a little bit about workflow. I think one of the key things that a lot of us have learned over the last few months is applying non-healthcare specific solutions to the healthcare space in the frustrations and lost opportunity costs, inefficiencies without specific alarming routing calls, understanding clinical workflows. I think those are all things that are really interesting observations over the past few months, and I think clinicians are getting more and more experience as we're trying to expand the scope rapidly to fit this new environment and to prepare not just for the new telehealth environment, but for additional waves potentially of COVID-19. So on the security side, I think there's always this balance between usability and security. How much are you leveraging patient devices versus basically only web browser versions? Same thing with provider devices. And so I think that's one of the things that we've got to really come to terms with. How much do we leverage because it's easy SMS, whether we think it's secure or not? The more that patients get targeted with SMS, and that's opening a browser, does that open them up to getting used to responding to text and doing things in more smishing attacks? It's things like that we have to be looking at and evaluating as we're moving forward. And again, I think it's that balance between usability and security, especially in the acute care environment where a lot of our providers are mobile. Another key thing is on the hardware. I think this is a major differentiator. Depending on what you're trying to use the telehealth solution for, sometimes desktop versions are better, but mobile is often better. And some of the use cases that we can look at, mobile technology is much easier to keep clean. It's much more cost effective. If it's built, if the software, the technologies are built correctly, you can actually leverage both patient as well as provider devices and shared device opportunities. So there's a lot of things to look at and consider. I think what I'd like to do now is kind of look at some of the traditional telehealth solutions out there. With the exception of fax, phone, and radio, this is not beating up on the existing systems or critiquing them. It's just highlighting what they were designed for and used for. So from a patient perspective, the patients are often stable. Obviously, the location was predetermined in many ways. The patients are often stable. What they're seeking care for is pretty well defined. I need an outpatient visit, or there is a stroke encounter going on. From a provider perspective, also, because a lot of these were driven by desktop versions or browser versions in the past, providers were often working shifts specifically to cover telemedicine, or they had allotted time during a day to do it. Often they're stationary. They're in well-controlled environments. They're providing care for something very specific or scheduled. Unscheduled patients and encounters are one of the key things in the acute care space that our systems are basically designed for. but a lot of times our technology solutions are not. Specifically digging into the technology, a lot of the technology we're using is not interoperable with each other, especially when you're looking at inter-organization communication. A lot of that at its core is still fax, phone, and radio. How much time does your transfer center spend leveraging just audio phone calls alone in connecting people? Some of the other things are the interactions. I think a lot of the interactions have been designed in the past to be very rigid, very specific for workflows on a very specific type of event. A lot of times they're really designed to bridge just two silos or two specific individuals at a single time for a very specific interaction or limited interaction. When you look at it from a patient journey perspective, and you look at all the different organizations, especially if you're evaluating the acute care space or patients that are unscheduled, that are considering entering the acute care space, or they're not following your normal protocols and apps that you've provided them, or access nodes or access points. If you start looking at the patients that slip off of that line and start going into more of the acute care space, look how many different organizations that are involved. And when you really start to break down how do we communicate between these organizations, telehealth offers an enormous opportunity. How can you have and leverage live video for these interactions? How can you create a sense of shared consciousness for a specific patient across these organizations? Can you involve the patient on the fly? Again, an unscheduled patient, how do you get them involved where you can do live video? Take a perspective of a burn center who would be this very far end over here. How could they basically accept patients from any other facility or organization using live audio, live video, whether all 350 organizations that send them burn patients, maybe they're not on a specific solution. How do you do that on the fly or get them to join? Other questions are, again, that star diagram on the far right side. A lot of our organizations have fantastic CC&C solutions, but how do those solutions help you with telehealth, with live audio, with live video, with creating a sense of shared consciousness for patients that aren't right now inside of your healthcare system? So I think that starts to highlight some of the opportunities that we have. I mean, the benefits that we can better leverage telehealth for can be not only operational gains, but in the new regulatory and reimbursement environment can also potentially increase the number of billable encounters that we have. So if you start to kind of break down some of the opportunities, we have to realize a lot of our patients are unstable or they're in transition. They're moving between organizations. When they start that movement, a lot of patients are undifferentiated. So if I have one solution for stroke and another solution for ICU and another solution for start to fill in the blanks, these undifferentiated cases, they could be going in and out, in and out, in and out of non-interoperable communication and telehealth solutions. Other things to consider when you start looking at the providers. So a lot of our providers, if I have a tertiary care facility, I'm trying to leverage my providers and make sure other organizations have access to those so that we can provide access in some of these underserved areas. But a lot of these clinicians, they're mobile, they're in chaotic environments. We have to figure out how to grab their attention and bring them onto a case. A lot of the conditions, again, are unknown. I think one of the really important things is if you look at that patient journey slide, there are a lot of middlemen that are involved. The transfer center is a good example. So how do you route something through a rural facility that goes to a state-based trauma network who then gets moved over to a transfer center and then involves the appropriate trauma surgeon? So these middlemen interactions, if you're focused on just point to point and it can't cross multiple different organizations, how do we bring all the providers on? From a technology perspective, I think there's tremendous opportunity to better leverage mobile and web. I think the goal should be, how do we leverage current cloud-based technology to eliminate silos while protecting data privacy and security? I think being mindful of healthcare-specific workflows is a tremendous opportunity that we have. And from an interaction perspective, I think it's really important that we're looking at thinking about flexible interactions across organizations. So when you start to kind of break down some of the new opportunities that are out there, and these are things that we've been seeing over the last 3 to 4 months, I'll be honest, some of these things we were designed for, but a lot of these things were emergence behavior of basically people looking at the need and trying to match tools to help fulfill this need. So some of the examples are, how do you take 911 calls or hotline calls that are audio calls, convert those over to video, be able to capture the data for this unscheduled patient, and either A, from an EMS perspective, maybe not even send a truck, or B, actually convert it over to a billable encounter. Other things like unscheduled behavioral health, I think that's really important. As an emergency physician, I've lived through years of having chronic patients come into the mental health patients come into the emergency department, and they hit those doors, and it's very difficult to get an appropriate disposition for them. And so now, if you can involve outpatient facilities, mental health experts, public safety, how can we provide better care where they actually are? From an EMS perspective, how can we better leverage video to actually provide medical direction, and in some cases even turn those into billable encounters? How can we work with EMS, whether it's mobile integrated healthcare, community paramedicine, to help leverage our specialists, those mobile resources to prevent readmission or provide chronic care in the patient's home. There are obvious things with transfer centers. How do we create a shared sense of consciousness across multiple organizations with a transfer center as a middleman that's operating logistics and all kinds of other things that they do, but being able to allow them from a consultation manner or from a transfer center mindset, how do we provide that access to all parties involved, both our own specialists within our system as well as in any potential referral facility? We've seen some of the most fascinating stuff in the ED and inpatient spaces. So we've seen areas where they start to undergo a surge in the emergency department, and now instead of opening up other areas in trying to bring in physicians and backlog and stuff like that, they're able to open up lower acuity patients to serve them where they are, and even recruit physicians that are at home that are quote unquote on call to provide those services. One of the things, if you think about limiting PPE and, preserving PPE and limiting clinician exposure. So imagine every emergency patient that comes in that qualifies, that has a mobile device, you can basically, in seconds, give them an app that they can receive secure calls on, instead of clinicians having to walk in that room repeatedly, donning on their PPE and exposing themselves, even for non-COVID specific patients. They can leverage that video for follow-up visits, follow-up communication, asking additional questions, giving discharge instructions. Other key things are family members. So we've seen a lot of people, obviously we have restrictions in the acute care space. How can we leverage live video and telehealth to basically involve family members in the patient's care when we have visitation restrictions? How can we better leverage telehealth if we're discharging someone from the emergency department, say it's an abscess or a cellulitis, or I need to make sure that there's NDI education. That's a specific code that we can do now. And I can follow up that patient the next day or over the next couple of days, instead of having that patient return to the emergency department. 80% of medical errors are secondary to miscommunication during transitions of care. So how can I leverage telehealth in chaotic environments to streamline and simplify transitions of care, even if it's internal? For time-sensitive emergencies, we're doing that across organizations, but what about even within my own facility? A lot of the inpatient scenarios are very similar to the ED scenarios, so I'll kind of speed past most of those, but imagine being able to leverage live video solutions where at-risk physicians or clinicians that are quarantined can still work and provide services if they're feeling up to it, and not physically being at the hospital. We're seeing a lot of virtual care centers that are being spun up. We can start to analyze outpatient spaces in different ways that hospitals and healthcare systems can leverage virtual care centers to better provide care. And I think one of the most interesting that we're seeing out there are the regional systems. So we see a lot of requests from emergency management now, whether they're building a MOC, a medical operations communication cell, so that they can communicate at patient level details for an incident. So they're used to incidents and have incident response software, but patient level details across organizations that can include middlemen like your EOC. So again, picture a evacuation where there's a COVID surge during a hurricane. How do we manage those patient level details, do appropriate load balancing, have not a command and control necessarily, but a communication and collaboration middleman that is helping. And those can be used for alternate care sites, long-term care facilities, et cetera. So those are a few of the opportunities that we can look at and assess our telehealth solutions. So I'll pass it back over to Tim for some additional details.
Thanks, James. Wow, that was a lot of detail around all of the different needs that are out there. And when you look at that, you really need to look at the telehealth systems with streamlined workflows to touch all of those different organizations. So with that growth, change, and the need to scale, what are some of the important things to prepare for in the months to come? The number one thing has to be considered workflow or streamlined workflow for all involved. The workflows within a telehealth system should be designed in such a way that simply providing the telehealth visit should support the necessary events for claims generations and processes. So, as we look at all of these different events in the slide that James just presented, it's really important that we're integrating these into our workflows and that they're just going to naturally flow. And as people are added or removed, we know the certifications and the level of those individuals, so that at the end of the day, because of the transition in healthcare going to so much telehealth, we need the ability to build these claims. So these next few slides are going to be focused on the ability to take on all of these changes and growth and the need to scale, and applying them to making sure you have processes in place that will allow you to do good claims generation and that entire AR process. So things to consider are medical necessity and medical need. Proof that the event actually happened, and that proof should be system timestamps that are not manipulated by individuals. Level of service provided. Do you know the certifications of the individuals performing the visit, so that you know that this is a service provided by a PT or OT or ST or a physician or an EMS provider in a MOC scenario? The length of the event, so that we can support the variations of CPT codes and HCPCS codes, and of course, the place of service in that overall structure. Important events after the actual telehealth visit. Everyone's so focused on actually doing the telehealth visit, right? And it's important to consider the workflows after the telehealth visit. And I always call this the fraud and abuse, guardrails. What QA and QI processes do you have in place? And do they reflect the CMS roadmap items? Excluding redundant actions and support the source of truth. Are you entering the data more than once and then entering it again and again And is the source of truth lost within all of these different systems that we're using to support that process flow or that workflow? Having work queues and filters with the ability to mark events as ready to bill. So in your QA process, do you have the ability to review events prior to passing them on to your billing solutions? And then the ability to mark events as exported, so that you know that, hey, I did my QA, I've got this event done, and now I sent it to my revenue cycle management solution, and I won't do it again accidentally, and again, and again in that process flow. And then being able to pull up build events to support the claim, as it's just a matter of time before OIG knocks on the door to audit these records. I mean, with this tremendous hockey stick growth, when we grew 11,000% plus in 3 months, it is only a matter of time before it's going to get a strong eye from OIG and making sure that we have all of the workflows and processes in place to make sure we can support that. And that includes the ability to get this information into the electronic health record. So the solutions that we're utilizing need to also be able to push it into the EHR for its final resting place. So with all these changes happening so quickly, and everyone's looking into the crystal ball and trying to predict the unpredictable, it's important during these times that the telehealth platform, that it allows flexibility to adjust to those changes. So does the system have multiple secure ways to communicate in both asynchronous and synchronous way, like video and group video, and the ability to, like in a group video, to add people, like James was mentioning, adding people to the team, like a language translator, in rural areas or in areas where they don't speak English or English speaking, can you add translators into the process and to manage that information? Is it secure messaging with and without templates? Do you have the ability to asynchronously message people, and can you do that with templates? Can you do an audio clip where you can record and forward and get that information to the necessary teams? And then, of course, documenting templates so that you can add consistency to the ease of the QA process. If every event is different, then every event is different. And that's very difficult to provide good quality systems. So having structures to support all of this is really important in the overall workflows in a good telehealth system. Can you easily bring on team members? Like I mentioned, a good example is a language translator. Can you do it during group video? So if the person is deaf, that they can read sign language. Those are important components. And if you have the ability to easily know who's available on a team, bring on those translation services, that would be a really nice service within that telehealth system. Do the workflows support simply adding others to the event? And at the same time, it's important to know what the certifications of those other people are that are being added to the event, because they can affect the billing rate that you can bill for that event. So, those kind of are the pieces of the puzzle that we have to make sure that to be really efficient and compliant, that we have that capability. Does the system also have flexibility to update things to support the need for the medical need side of the equation? You can't just do an event because you can do an event, right? You can't just have a telehealth call because you can. There's got to be a medical need component to that. Why are you doing it? And you need to support that with the procedures that you performed, the medications that you provided, in your notes, etc. And all of that information will help support the medical needs side. So jumping ahead into the telehealth guidelines, as it relates to HIPAA, James had mentioned it's really important that as we're looking forward, that even though HHS waived the requirements to several of the HIPAA guidelines, it's really important that we all realize that those are coming back. When they in March 15th, they had a waiver, a HIPAA waiver that allowed the ability to not require a patient's agreement to speak with family members and friends about the care, the requirement to honor a request to opt out, the requirement to distribute a notice of privacy in practice, the patient's right to request privacy restrictions, and the patient's right to request confidential communication. All of that was waived during the pandemic, and rightfully so, because we had a lot of adjustments to make. But it's clear that all of those requirements are going to make their way back, and any organization or any telehealth solution that you're looking to for the future needs to meet those requirements. So some HIPAA guidelines post-pandemic is, and considerations post-pandemic are: expect the Office of Civil Rights to not extend the waiver. And so when evaluating the software solutions, make sure that they're built for healthcare. As we all learned over many years, that people that have focused on healthcare, HIPAA-compliant healthcare solutions, are really good at what they do, and they understand the reasons behind what they're doing. And it's not just telehealth. It's not just launching a way for two people to see each other. They're doing it in a HIPAA-compliant way that keeps it HIPAA-compliant through all the workflows. The organization must sign a BAA. The organization must or should have advanced security certificates. They should enable end-to-end encryption and avoid storing any local data. And of course, comply with the security rule in respect to allowing authorized users to access the EPHI. So not only during the event, but post-event, who has access to this information. So with that, James, I'm going to pass the baton back to you.
Great, thanks, Tim. I only have a couple of slides left, and actually there's a question that I want to go ahead and field now. So one of our attendees asked, one of our biggest challenges in healthcare is the lack of interoperability across the continuum. More technology, different systems which do not communicate, from telehealth to urgent care to hospital to physician office. How are you integrating into one patient record? So I think that's a good lead-in. I just wanted to spend a few seconds on how we are trying to address inter-organization team communication in a telehealth solution. So at Pulsera, instead of opening up all of these different communication channels that you see, what we do is we create one single dedicated patient channel. So this can be started anywhere at any location. Step 2 is you dynamically build your care team on the fly. And what that means is you can add a new healthcare organization with a tap. Within an organization, you can add a team or an individual. And then step 3 is you can leverage that as your telehealth network and then basically communicate. So that means live audio, live video, but there's also things like messaging, ETA, images, audio clips, other multimedia vendor integrations, data repository integrations, those type of things. So when you look at that from an organization perspective, I think it's kind of important to look at, well, okay, how do you patch a system together within a metro area or within a rural area? So any organization can start a case. They can involve internal care team members. They can even use our patient-facing app and involve the patient into that red line, into that patient channel. And so just within an organization, you can leverage Pulsera. But at any point, if you want to consult or transfer to another organization, so I just need your opinion, or I need to transfer ownership, you just add that organization in with a tap, who can also add their internal care team members, patient or family. Together they can have the interaction and stop it, or they can just keep adding and keep adding and keep adding organizations. And so that's how basically we are able to pull everybody together. I think how do you sell, who's the client, who buys something like this, kind of comes into that, because people aren't used to regions being consolidating it down around one thing. And so I think it's important to look at, we have EMS agencies, we have hospitals and healthcare facilities, and we have a MedOps package that's targeted at emergency management or state-based transfer systems or regional systems that are either command and control or a communication and collaboration mindset for selecting destination. So we have free and paid versions on the EMS and hospital end, so we can unite the entire country, replace the traditional radio report or hear report with a multimedia report, including ECG transmission, and that's free to EMS and free to hospitals. If EMS wants to upgrade for select services, they can. If hospitals want to involve downstream team members, they can choose to upgrade as well. Other things is all referral facilities, nursing homes, urgent cares, some of the other places, physicians' offices that were listed in the question, they can join at no charge and use to live audio, live video to transfer patients. So I think those are some good ways, and of course the MedOps package can come in and overlay and help regions. So one of the key things is we can mix and match these packages into bundles. And the final comment out there is we are obviously in dire financial straits as a healthcare industry. We're all struggling with elective procedures being delayed, postponed, stopped altogether. One of the things that I think is important is there are tons of grant and funding opportunities. We've actually identified not hundreds of millions, but billions of dollars that can be used to help regions band together. And so we can help you from an individual EMS agency or hospital or health system, or work with larger groups such as metro areas, regions, RACs, all the way up to states to put together a package that makes sense for you. So with that, I do want to read a few of the things that people are thankful for. So one of the things that is kind of a resounding theme on a lot of the feedback from the audience is spending time with family. So meals and with family for sure, chance to be aware of every blessing. My favorite family-related comment is actually getting my 17-year-old to choose to spend time with me. #priceless. So some of the other things I think that are great are being able to slow down and focus on what really matters. Another one said it this way: I'm thankful for the slower pace, less going and doing, and more just being. I'll close these comments, or actually I'll do two more. One is telehealth, more comfort with innovation in transforming systems and local and regional networks actually working together, not always competitors. And I'll close with Matthew. Matthew, I won't disclose where you work, but his was not wearing pants. So with that, I will hand it back over to Brian.
Thank you so much, James and Tim, for that excellent and incredibly timely presentation. And thanks to all our attendees for sharing those positive vibes. We definitely appreciate that. And we will now begin today's question and answer session. So please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we will get through as many as we can. We've had a bunch of great questions come in already. The first one we'll kick it off with is the attendee writes, telehealth was conceived to solve a lot of problems. A language barrier is not one of them. Are telehealth providers doing enough to address the need for integrated language assistance for deaf or limited English-speaking patients? What more can be done to ensure compliance with the law as it relates to language access?
Yeah, great question. I can kick that off. So there are more and more people leveraging mobile technology where translation services are local on the device and therefore secure. There are also dedicated services. It's one of the main reasons why we were focusing on the ability to dynamically build your team on the fly, and that can include anybody. And so there are a lot of services that are out there that do provide that. And so with a tool like Pulsera with flexible interactions, you can bring them in as a care team member and they can help from a group interaction standpoint provide some of those services. So those are a couple of ways, and I think that is an area that's ripe for disruption as well.
Thank you for highlighting those tools and those services. And the next question we have here, I believe, is an attendee asking for a clarification on a comment from Tim. So did Tim say only audio appointments are accepted for CMS, no video?
No, that's not correct. It's audio and video. The difference is the audio side is being accepted now during the pandemic, and those are billable services during the pandemic. It'll be interesting to see how that plays out going into the future, but it is audio and video, to answer the question specifically.
Thank you so much for clearing that up, adding some clarification there. The next question we'll take, and we've had a bunch of great ones come in. Really appreciate all this great engagement. So the next one is, what potential do you see during and beyond the pandemic to use telehealth to incorporate primary care providers into inpatient roundups? For example, primary care joining via telehealth for consultations with hospitalists or surgeons when their patient is in the hospital to improve continuity of care and strengthen referring provider relationships.
Yeah, I can comment on that one. So there's two different components to that question. One is the technology. I think the technology exists to basically pull in a clinician for rounds, and that's probably a lot, especially in-system providers. They can leverage solutions that they probably already have to do that. Solutions like ours are able to do that even outside, bringing in non-primary or non-affiliated providers. However, I think schedules and protocols and procedures as far as timing on those, as you know, those are often very difficult to align best case scenario, and rounds often go late, and actually scheduling those and disrupting clinic is probably going to be one of the primary challenges for them to join synchronously. I think there's massive opportunity to involve them with asynchronous communication in tools.
Thank you so much for tackling that, James. The next question we'll roll into is, the attendee asks, how are organizations handling the relaxation of state regulations allowing out-of-state providers to treat patients with 1135 waivers? What does this communication plan look like, and what controls are in place to ensure providers are complying?
Sure, Tim, do you want to take first pass at that?
Yeah, I can. That's a very good question, and I really, it's going to be interesting to see how this really plays out. I think time is going to tell how it's going to end up post-pandemic, and I think that's really what the question is focusing on. And the state waivers and crossing borders and all of those kind of things are still up in the air, and how that's going to happen, especially beyond CMS, and how the parity for other payers is going to handle that. So other than to say at a high level, I think we're going to have to watch and keep an eye on that specific thing. I haven't seen anything that really explains that in detail.
And I haven't seen where people are talking about that being something that is going to be persisting as well. So I haven't heard a lot of chatter about that. Great question.
Yeah, it is great question.
Well, appreciate you both, weighing in there and offering some added clarity there. So we are almost at time. So we'll do one more question, and I'll invite Tim, James, any closing comments for our audience. You can make those at this time as well. The last question we'll go with here is Pulsera compatible with Epic and its App Orchard for wound care telehealth?
So high level, go ahead, Tim.
Okay, sorry. So at a real high level, we do have integrations, capabilities to all of the major providers, Epic, Cerner, Allscripts, and so on. Specifically as it relates to wound management, We haven't necessarily gone down that avenue yet today, but we do have the ability to move our information from our solution into the different EHR solutions that are out there.
Well, appreciate you both for tackling all those questions, and thank you to all our attendees for being so engaged and asking such thoughtful and detailed questions. So James and Tim, that was a great presentation. Thank you so much, and I want to thank Pulsera as well for sponsoring today's webinar. So enjoy the rest of your day, everyone, and we look forward to having you join us for future webinars.